Hello, good afternoon, and welcome to Community Conversations with Oklahomans for Criminal Justice Reform. I am Jacqueline Blocker, Engagement Director for OCJR. I want to thank each and every one of you for spending some of your time with us today. Oklahomans for Criminal Justice Reform is a coalition of business leaders, community and faith leaders, law enforcement experts, service providers, and advocates who promote public safety in a way of addressing evidence-based and data-driven policy reform that will address our mass incarceration crisis. There are very many reasons why the mass incarceration crisis should be addressed. Saves Oklahoman taxpayer dollars, and one of the most important aspects of it, which we're going to focus on today, is mass incarceration as a public health crisis. The pandemic has shone a light on so many areas that we need to focus on, and I think that the mass incarceration crisis and the pandemic are definitely one of them. So there's been so much amazing work done with advocates and in DOC and trying to do the very best they can to attack this unique and challenging circumstances. And so I'm honored today to have our panelists here to discuss this. I am so pleased that DOC very quickly responded to and accepted our offer to speak about this issue. And we have representatives from the Oklahoma Policy Institute. They're going to discuss some of the statistics, and then someone from OCJR that is going to talk about some other states and some best practices. So before I get on to our amazing panelists, let me first address and introduce some other members from our OCJR family. This way we have Callie Watkins, who is our reentry coordinator, and Colleen McCarty, our policy counsel, recent graduate of law school, and she's also a panelist today. So without further ado, let me get to introducing our first panelist. And I'm also going to tell you, Tammy Franklin of Prison Fellowship is also going to join the panel. I'm trying to get her on. We're having some of these wonderful technical difficulties, but hopefully I can get Tammy to join us so that she can discuss some of her amazing outreach work in the prison system. So let me start first with Mike Carpenter, who is the Director of Institutions with DOC. Mr. Carpenter, thank you so much for taking time with us today, and I will turn it over to you.
Thank you, Jacqueline. I appreciate it very much. See if I can get it where I can. Okay, I think I'm on, and I think I've got everything lined up. So really, they had asked that I come and talk about a review of the rapid response to the pandemic, the measures that we took right away. And so I'd like to start by saying, thankfully, the director of the Department of Corrections, Scott Crow, had the foresight to see very early on that this was going to be a bigger problem than everybody thought that it would be at the time that we were having these initial discussions. So right at the end of February, beginning of March, everyone was talking about it, but nobody was talking about it in real serious, like truly pandemic terms. And the director had the foresight to see, even at that early point, that we needed to really ramp up our response early. And that turned out to pay off in a very big way later on. We'll talk about that in just a second. So essentially, a lot of those early responses was to get us to a footing where we were practicing stay home, stay safe earlier than just about anybody else in Oklahoma. And what that meant was that we had to make some very difficult decisions. The first was that we turned off visiting. Visiting is a huge thing for us. Families really need the assurance by seeing their loved ones on regular occasion. They really need to feel like that they're connected with their loved one, especially when something like this pandemic takes place. And so turning off the visiting was a huge thing for us, because that puts it to where everything is a telephone conversation. And just going to be honest, that telephone conversation is not necessarily reassuring to a mother or grandmother, a father or grandfather, because you can't see the person. And so, but doing so also allowed us to limit the exposure to the facility. Another thing that was pretty immediate was that we turned off volunteers from coming to facilities. Well, that's another huge thing for us. Volunteers are huge for us. A huge percentage, I'm going to say probably 70%, maybe 80% of our inmate programming, inmate betterment programming, comes through the volunteer resource. And so if we stop volunteers from coming in, essentially what we do is create idleness, and idleness is a terrible thing in a facility. You can imagine that inmates like to keep themselves busy. They want to work, they want to go to programs, they want to learn, they want to expand and grow as best they can through all of the different things that are available. So again, turning off volunteers was a huge loss for us. And so then there were steps that initially, right at the very beginning, we placed facilities into a lockdown. That's always a challenge, because lockdowns become staff intensive, and it also then limits our ability to let inmates interact. I mean, a lot of how inmates respond to things like a pandemic is based on how they interact with each other and how they interact with staff. And so we rolled out of that as fast as we could into a modified movement situation. And essentially that modified movement matched what we were all doing at home. We started limiting inmates' access to person, place, and thing. And so that what we were trying to do was get them out of the cell as much as possible, while at the same time limiting their access. So we stopped going to food service, we started bringing all the food down. We stopped going to medical, we brought all the medical down right to the unit. And so since they were already on the unit anyway, and they were already exposed to the people they lived around, in some cases anyway, we allowed that access to continue. And so at least that allowed them to interact with the people that they lived around and the staff that they worked around every day. And so essentially what that did for us on the response side was it made a very small circle, but we could allow almost unrestricted access to that small circle. So, and that's essentially where we stayed. We had a few inmate workers out. Food service is very dependent on inmate employees to come to work. Maintenance is very dependent on inmate employees to come to work. And so we allowed some of that to continue, essentially the essential worker thing that was happening on the streets with the rest of us. And so through those efforts, what that allowed was us to ramp up to a very high sanitation and sanitizing schedule. It allowed us, as we started getting shipments of masks, we could start putting inmates in masks and keep that going. It allowed us to keep that circle very small. The same was true for me. I went to work, I went to CVS, and I went to every drive-through that any person has ever heard of for food. And so my circle stayed very small as well. So, and we stayed in that environment until yesterday. And what we did yesterday was kind of a phase 2 reopening. As the governor has talked about some of the reopening, yesterday we opened that small circle. We opened it up a little bit wider so that inmates in their living groups can have access to the wider yard areas, which allows them access to like a ball field area where they can get more space to exercise. Some of that, some of those widening out a little bit of that pipeline so that inmates can have more space to move around in. I think that's important because, if we have cabin fever, that's triply worse for offenders. They're really, when we say a small circle, that small circle is very small. And so at least I can move around in my whole house. An offender moves around in a small cell and then a little day room area with a shower and a telephone. So really, that's about the size of the emergency responses. I would like to credit the director with his forethought in all of that, because to date, knock on wood, you see me knocking on wood, we have 2 positive offenders. One of those was found as a discharge, and we have 10 positive staff. So while those measures were measures that we knew what we were creating, the results is gigantic for us. Only 2 positive inmates is gigantic compared to what's going on at facilities around the nation. So I'll kind of stop there. If there's some questions I can answer, or we can wait. Jacqueline can ask for questions at the end.
Thank you so much for that, Mike. I appreciate that. And I want to make sure that our participants know that they can submit questions through the question and answer button. And we will be sure to get those questions to our panelists and hopefully be able to address them, all the questions that come through. But please feel free to submit any of your questions and answers to the panelists throughout the webinar. Thank you so much, Mike. I'm going to go ahead and kick it over to Mary Stevens, who is the nurse, the director of nursing, is that for DOC, and she is going to share a little bit of information with us. Justin Ferris had an emergency, so was unable to join us, but Mary has agreed to step in at the last minute. So thank you so much, Mary, and I'll turn it over to you.
Thank you. Good afternoon, everyone. I was just going to talk a little bit about testing. Mike kind of touched on this a little bit, that we only have 2 positive cases. Early on in this pandemic, we looked at our pandemic plan, and most of it revolved around the flu. So obviously we had to look at our pandemic plans and change those up to make them specifically address coronavirus and what was going on with coronavirus, which is obviously, as you all know, ever changing every day. The CDC put out a really good guidance on management of coronavirus in regards to testing, and so in conjunction with the health department and the CDC, our chief medical officer looked at testing and guidance for his providers on when to test, what to test. So he laid out a really good plan of what you should do and what steps you should take when you decide to test an inmate. And that is all kind of guided through our pandemic plan. So early on, once the pods were locked down and when this all started, medical staff began walking units, which that doesn't happen every day. You know, usually they fill out a sick call request and we triage those and they come to us. Well, we went to them, not only to deliver pills, but to do wellness checks on every unit or cell to cell, just checking to make sure inmates were not having symptoms, they were not having any problems. If an inmate is questionable as being symptomatic, they are, use personal protective equipment. We pull them out and we screen them and decide whether they need to be tested. They are also tested for flu and strep before they are tested for COVID-19. So there's a lot of things that the provider has to do by using his assessment skills, and the nurse, before they decide to test. On April 20th, we began expanding our testing to testing every inmate that discharges, so they can feel safe going out to their family, knowing that they're not taking this out there, and their families can feel comfortable with that. When that happened, we had one particular inmate that was tested, and that was the week we started. It was like on a Monday. He left early Wednesday morning and his test came back positive. So we immediately made contact he was going to some specialized housing with the county health department, tracked him down, did contact investigations, with guidance from the health department, tested everyone on his unit because this was an open dorm. It was kind of like the way I can explain it is a dorm room where you've got 4 inmates, you've got a bathroom, kind of like a Jack and Jill bathroom, and then 4 inmates on the other side. Plus, the pod is open, so they can come in and out of their rooms just on that pod. At this time, the director had already started having inmates wear masks. We were doing social distancing, which was what's a great asset, because you didn't have the whole unit walking around. You just had that pod, which included 52 inmates. We tested every one of those inmates and they all came back negative. So once we started testing discharging inmates, since then we haven't had any come back. But to date, we've tested, as of this morning, 1,405 inmates. 120 of those tests are pending, and the majority of those are discharges, inmates waiting to discharge. And we actually started testing inmates a lot sooner before their discharge date in order to get those tests back before they discharge. We've had 1,283 negatives. So our numbers have been really good. And like Mike said, the director did a really, really good job early on with some aggressive measures that really has benefited us. The other positive we had was early on, an inmate had gone out to the hospital, began exhibiting symptoms at the hospital. He actually went out for an overdose. They tested him, he was positive. 292 inmates on his open dorm were tested and they were all negative. So, some pretty aggressive testing went on there, which we were obviously very relieved that nobody else was positive. And that's kind of, as we open up, we're going to continue with the nurses doing wellness checks. And, I know that Mike could probably talk more about more things that are happening as we open up, but obviously very cautious and very following, CDC guidelines and in conjunction with our local health department on some things that we can do to continue to have such good numbers.
Thank you so much for that, Mary. And I actually have a question here that I'm going to go ahead and read while you all are kind of up. It's a question from Jane, and she asked, hello, currently the Oklahoma County Detention Center has over 300 inmates that are waiting to be transferred to DOC. When will DOC start accepting inmates from county jails? And I'm sure probably a follow-up is there a plan or procedure in place for how we're going to start accepting those inmates? And thank you for your question, Jane.
Yes, ma'am. That's a very good question. I'll provide a little bit of an answer. The quick answer is we're working on a plan for what that would look like right now. The long answer is that what we would like very much is to be able to start doing inmate receptions in fairly short order. We understand we're very appreciative of the county sheriffs and the Sheriff's Association for working with us in holding those transfers and allowing us to maintain each facility as its own little island and not be importing additional people throughout the emergency part of the pandemic. But we also understand that those people need to move on and they need to get to the processing that happens at LARC or MBARC. And that way, a lot of those people can get to their facility of assignment and get to the security level that they should be at. Because, again, speaking about the Oklahoma County, we can safely assume that a lot of those people might be at minimum security or even at community security if we could get them in and get them processed. So the agency is working on a plan right now for what it looks like to restart that, and we hope to be able to restart that in fairly short order.
Thank you for that. That is very good. Let's see. How about let's move on to Damian Shade. of Oklahoma Policy Institute. He, again, is the criminal justice policy analyst and just amazing wealth of knowledge. So I'm going to turn it over to Damien and let him enlighten us a little bit about the aging population and some other compromised groups. So thank you, Damien, for joining. I really appreciate it.
Thank you, Jacqueline. Thank you for the opportunity to just talk about the seriousness of these issues in our state. And I just want to begin by thanking the exemplary work of Scott Crow and the Department of Corrections to really try and get in front of this crisis. I hope that our lawmakers and people across the state will do whatever they can to give positive encouragement to those corrections staff and those medical staff who've been putting themselves at risk and going through these new procedures to try and keep those who are justice involved and their families safe. So I'm really grateful for that. I'd also like to give a note of gratitude to Matt Elliott, who has gone above and beyond with me to really try and give me detailed information on the healthcare situation inside our prisons, just the number of immune compromised individuals and those who are really at high risk. So I'd like to really just give a note of gratitude for all of the positive work they're doing. At Oklahoma Policy, really the things that we've been focused on in responding to COVID-19 in our prisons are kind of fall into three buckets: increased hospitalization risk and pre-existing condition risk, increased age and demography risk, and then the long-term nature of the COVID-19 threat. So those are really I'm just going to briefly kind of go over some of the data that our Open Justice Oklahoma program at OK Policy has been able to analyze about the demographic makeup of our corrections population at prisons across the state. As we know, a large number of our corrections facilities, as they are in most states across the US, are in rural counties. So this really presents a particularly acute risk for hospitalizations that might have to occur outside of the corrections settings for those patients with presenting the most acute symptoms of COVID-19. And since 2010, Oklahoma has actually seen the second largest closings of rural hospitals in the nation after Tennessee. And so we know that there is a lack of access. We know that it is a particularly precarious situation that our corrections staff has had to manage. When you combine that with the acute health risk and chronic conditions that we see amongst so much of our Department of Corrections population, then you have a really difficult situation to manage. So for example, as of this April, there were 2,997 inmates who were being treated and monitored for hepatitis C, for example. That's about 12% of the overall incarceral population of state prisons. We see somewhere in the neighborhood of, depending on how you measure it, between 10 and 14% of our incarceral population with respiratory conditions that could be considered chronic. We see a little less than 11% of our incarceral population being treated for diabetes. And some of those populations overlap. So there may be individuals who have respiratory conditions and hepatitis C, for example. So you may see some overlap, but we're looking at a significant percentage of immune compromised individuals in corrections custody across the state, which just increases the level of risk, increases the amount of work that our corrections staff and law enforcement are having to do as the county jail process reopens, as they were just speaking of. It will be those individuals who will require intensive monitoring in that process with these chronic illness, with the particular pre-existing conditions that make the COVID-19 threat so much higher for them. The other place the second area that I kind of want to go into briefly is just the increased demographic threat that we see from the aging population across our Department of Corrections. So we know that more than 12% of the Department of Corrections population across the state is over 55. The CDC has placed people 55 and over on a particularly high risk level. Obviously, 65 and older is considered an acute risk level factor. But we see a large population across the state that really falls right squarely into that statistical guideline. One of the places that we've seen the highest level of risk is James Crabtree Correctional Center. It's located in Helena. It's a medium security prison, houses about 1,000 male inmates. About 200 of them are in minimum custody, about 800 are in medium custody in an average time. And so we see in that facility a larger than usual and even more disproportionately aging population. So the number of people in James Crabtree that are 55 to 64 is actually 21, almost 22%. The number of individuals that are 65 to 74 is 7.5%, nearly 100 individuals. And then the number of individuals in that highest age class of over 74 is 2.2%. We actually see a larger than proportional share of individuals at Howard McLeod Prison is another spot that we've sort of highlighted and looked at with some demographic risk. 12.4% of that population is between the ages of 55 and 64. Even though the risks are significantly less substantive, we've also looked at Eddie Warrior, which has a somewhat higher age demography population as well. And the issue here is really the hospitalization risk, the ability to manage those symptoms, to apply ICU and ventilator care when that's necessary, becomes much more precarious for people in those highest age groups. When you combine that with what we know about immune compromise, then we see a threat level in our Department of Corrections which is disproportionately high, even for high carceral states like Louisiana and Mississippi. Mississippi probably has the comorbidity picture in its prison population that most closely mirrors the comorbidity picture that we see here in Oklahoma. But the lack of access to rural healthcare resources could make this problem much more difficult to manage over the next 12 to 18 months, where hopefully antivirals and vaccines will become a more substantive part of our response to COVID-19. Which leads me kind of to the final point. The long-term nature of this threat is really the thing that we're going to have to be thinking about as we move forward with our county jail system and our court system beginning to see churn. That will be the real difficulty, depending on how you measure it between rated capacity and actual facility capacity. Our prisons are either 107% over capacity or 103% over capacity. In either of those statistical cases, you see pronounced difficulty for the correction staff, as the two panelists have already described. It has required some real flexibility amongst our corrections staff, some real flexibility amongst our medical staff to do the wonderful work that they are doing right now. And I believe it's going to require increased investments in resources for them, probably increased investments in some type of temporary staffing. And OK Policy continues to advocate for the increased use of medical parole and other devices like commutation to really lower some of that stress and strain on the system, because we have really dodged a remarkable bullet by only having those two positive confirmations thus far. As we've seen from the outbreaks that are currently happening in county jails and in the federal prison system here in Oklahoma, there is no guarantee that this positive outcome that we've seen so far will last in perpetuity. So it's very, very important for us to begin the process of starting that conversation about what will the long-term impact of this look like. And the last thing I'll say to that long-term question is, so much of this is happening in a racialized context, which I hope we are recognizing. The racial disparities that exist in the Oklahoma prison population are something that take those extra acute risks and make them more pronounced. We've seen that more than 80% of the COVID-19 hospitalizations in Georgia have been African Americans. In Louisiana, more than 70% of the people who died from COVID-19 are Black. In New Mexico, American Indians make up less than 10% of the population, but over a third of the COVID-19 cases. And these racial inequities intensify the virus threat to our prisons. We have the highest Black incarceration rate in the nation, with 1 in 15 adult Black men, folks who look like me, incarcerated in our state. And Latinx and Native disparities are also fairly acute in parts of the system. If we are going to combat this using the best data, we've got to find ways to prioritize the release of these higher risk communities, as they also correspond with comorbidities and lack of access, especially to the rural healthcare infrastructure that's going to have to serve a large number of these individuals. So I'm so grateful for the amazing work that our corrections officers and our leadership have done so far. And I'm urging for those who care about this issue to continue to advocate, to give law enforcement and corrections staff the tools they need to keep these populations safe. Thank you, guys.
Wow, that was amazing. Thank you, Damien. That was a great overview. And before I go on, I'd be remiss. Let me introduce the rest of our OCJR family that joined. Chris Steele is our executive director, and he is on the panelist. And Elizabeth Mashburn, our office administrator, is with us as well. And also want to officially welcome Tammy Franklin of his fellowship. I'm so glad that you are with us, so thank you. All right, I am going to turn it over now. I'm going to Colleen McCarty. She is newly graduated from law school, taking time out of her rigorous bar studies to share with us some information about what other states are doing in light of the COVID-19. So, Colleen, take it over. Thank you so much for taking time out of bar studies to be a part of the panel.
Well, thank you for having me, Jacqueline, and I want to echo everything that Damien was saying about, you know, for our on-the-ground workers, for Mary and Mike. I know this has been an extremely stressful period of time in your lives, probably in your most stressful in your careers thus far, maybe, and I just want to say thank you to all that you're doing. I know that this is probably thankless work in a lot of ways, and there's maybe never enough time in the day to address everything that you have to do. So thank you for all you're doing. The first thing I wanted to mention is that last Friday, myself and some other advocates turned in a petition to Director Crow and Dr. McCurdy to seek for an enhanced use of medical parole in the system for pregnant inmates, for those who have 30 days to 6 months left to serve, and for those over 60 and those who are immune compromised. And I wasn't sure if the two of you knew about that getting turned in last. It had 1,002 signatures from people across Oklahoma that would like to see an expanded use of medical parole. So I just wanted to mention that. I haven't heard from him yet, but that doesn't mean that I won't. I'm sure he's very busy. So I'm going to talk today about sort of like an overall picture of COVID-19 in US prisons, and then best practices of what other states are doing in response to this, other state prison systems, and then a little bit about a lawsuit that occurred in Washington State around this issue. And then I wanted to go over some survey results from other prison systems that was submitted to the National Commission of Corrections Healthcare. Probably Mary knows that organization, but they have an ongoing survey every week that they allow departments of corrections to submit their responses to for how they're dealing with this. So that'll be the last thing I talk about. But first, there are 25,239 total COVID cases in prisons in the US currently as of May 13th. Of course, we have a lag on the data. That includes the federal system. That's a 25% increase from the week before, and there have been 372 deaths. And you can see a large increase probably because there has been a large increase in testing, which is what we've seen in Ohio, in Arkansas, in Texas, and other places. There's just been a big explosion, as to say, now that there's a lot more tests available. Explosion in testing is always probably going to lead to an increase in positives. As far as best practices in other states, the best practice continues to be being proactive in releasing people who are no longer a public safety threat, and those releases allow for easier social distancing inside. In Arkansas, they've released 1,200 people, or they've at least made 1,200 people automatically parole eligible. So that happened in the last week. In Wisconsin, they've released 1,600 inmates, and the majority of those were detained for technical or parole violations. In Hawaii, which Hawaii has a combined jail and prison system, so it's not exactly the same, but I still wanted to mention it. They have worked with public defenders to release 655 both pre and post-trial inmates. So we are seeing a response across the country to reduce prison populations where it is practical and safe. I know that the Pardon and Parole Board in Oklahoma has looked at what we can do with our existing statutory framework, because the governor's emergency order only allows for agencies to suspend regulations. It doesn't allow them to suspend statutes. And a lot of our parole guidelines are statutory. So we can't just, like Arkansas made everybody immediately parole eligible. We don't have the ability to just do that. However, with people who do not have a victim notification requirement and who are within 18 months of release, those people can be streamlined onto a medical parole docket. And the Pardon and Parole Board has said that they are supportive of using the docket in that way. So it's something to think about as things maybe change over time. I know our numbers have been very good, but like Damien said, to remain vigilant and remain proactive, it's important to consider maybe what vehicles we have to reducing the population. In Washington State, there was a group that brought a lawsuit, a writ of mandamus to the Supreme Court in Washington, asking for release of anyone who is immune compromised, anyone in the system who was pregnant, and anyone who was over the age of 50. And they had plaintiffs from each of those categories bring the suit. It was a very narrow decision from the Washington Supreme Court that actually came out on the side that said that the DOC was doing enough to protect those inmates. But if you read the brief, you'll see that the things that they're doing have been a lot like what our DOC has been doing. I was comparing sort of what Mike was saying with what the Washington DOC was doing. And the only differences that I can see are that they have been screening staff and doing temperature checks on staff every single day since middle of April. I know our DOC has been doing this too, but they've been manufacturing face shields and face masks and sanitizer and distributing that throughout the system. They had like very large numbers of PPE available. They also reduced movement in the system, and they actually had like a communication strategy to the inmates about how to social distance inside, how to remain clean, what hygiene practices they could practice in order to be safe. They also allowed for social distancing inside wherever it was possible. So if there was any work crews or anything like that, they instructed all the work crews to make sure that they were social distancing inside. They also had medical ventilators and adequate medical technology available inside all of their prison medical facilities. And I'm not sure what our current status is of that. I think Mary might be able to say better than I can, but so those were some of the reasons that the Washington Supreme Court felt that their DOC was doing enough to protect their inmate population. Lastly, on the survey from it's the National Commission on Corrections Healthcare, and they gather survey results. It's a self-reporting survey, so it's not 100% of the system, but some of the other best practices that they have been reporting are that some facilities are doing plexiglass installation at various touch points. Some are doing, of course, they're doing quarantine and screening of all new detainees, and we haven't had to address that yet since we haven't been accepting new detainees in LARC or Embark yet, but that's something to think about. Masks for all the inmates. They've been doing data collection. I know DOC has a tracker on the website that is updated daily. It's just a day behind. So we are seeing you guys do a lot of what other states are doing in response to this. The only other thing that I would just want to bring up is that a lot of prison systems are allowing for free phone calls and iPad phone calls so that they can have video chats with their family members. Something that Mike mentioned is that it's very tough on inmates to not be able to contact families. And I know that some of the restrictions on visitation have been eased up, or they're about to be eased up in the next couple of weeks for immediate family. But considering maybe like a sanitized iPad that you could provide for free phone calls is something other systems are doing. And Oklahoma is already doing this, but the not allowing any medical fees for any flu-related medical visits to the infirm is one of the other things that some states are doing, and we are on the list of people doing that. So again, thank you so much for letting me share this information. I hope it's been helpful to anyone, and happy to answer any questions too.
Thank you so much, Colleen, and that's an amazing amount of work, and it is good to know, encouraging to know that we know that DOC is doing all that they can and continue to do so, and we will address maybe some of the challenges and that they have faced once we hear from our next panelist, Tammy Franklin. She runs she's a part of Prison Fellowship. She's inside the prisons working with the women. I've had the honor of visiting Tammy and a couple of her Prison Fellowship classes. In fact, Susan Esco and myself visited Mabel Bassett's correctional facility. I think it may have been less than 5 or 6 days before the lockdown. I mean, it was so timely, and I have to tell you, I think about that on a daily basis. Had we delayed that by a couple of days, I would not have had that opportunity to see those women and to speak with them. And hearing their stories is my booster shot when I need some inspiration to continue, because this is hard work. And so Tammy Franklin just does amazing work. So I'm going to turn it over to Tammy so that she can talk about some of the challenges with outreach and share some of the stories that she shared with me about the women reaching out to her and other volunteers. So thank you so much, Tammy, for your time, and I'm going to turn it over to you.
Thank you, Jacqueline. It is so good to be here. Thank you for the invitation. It's good to see everyone and hear what's going on in each of your departments. When you talk about the day that you and Susan visited, it just about brings me to tears, because there was a lot happening in the classroom that day and a lot of heartfelt stories that were shared, and I continue to hold on to them as well. Before I kind of get started on how COVID-19 has affected prisons, I just want to absolutely say to Scott Crow, the director, and the Department of Corrections staff, job well done. Job well done. We absolutely, I see the nation numbers. Prison Fellowship is a nationwide ministry or organization. And so I see the numbers of the other facilities across our nation, and Oklahoma has done an exceptional job. And so I just thank you for that. It was back in March, in fact, when my contact at Mabel Bassett Correctional Center contacted us and told us for the safety and security of the men and women in prison, that our programs had been put on hold for a season. And my first reaction was, oh no, because I love what I do. I love being in the classroom with the ladies. But I think just like most people, if not all of us, understand that it was out of necessity that they put the programs on hold. And so what I love about Prison Fellowship is our leadership. One of the things they didn't do is they didn't spend a whole lot of time worrying about what we can't do. And they moved right into asking the questions, okay, then what can we do? And so we began to recognize, again, was reminded of the importance of the public and private partnership that we hold with DOC. So we began to brainstorm with the Department of Corrections and just to come up with what could we do as an organization to inspire and encourage the men and the women on the inside. And so some of the things that we came up with is we partnered with Celebrate Recovery and the Alpha program with an organization called Floodlight. And through Floodlight, we were able to present a platform to the Department of Corrections that allowed positive digital content to be viewed on the televisions of the men and women in prison. And so they were able to get some CR meetings, they were able to get some Alpha programs, they were able to hear testimonies of men and women who had previously been incarcerated and now are out living successful lives. So I think that was a win-win for everyone there. We were affected, Prison Fellowship was affected. We have 7 academies in the facilities in Oklahoma. Some of them have the program, like the one that I lead, is 500 hours of curriculum where we teach men and women how to become good citizens. And we talk a lot about pro-social communities and what that looks like, and can you live a pro-social life in prison. And so those 7 programs were put on hold. And again, back to the question, we just began to look about what we could do. And one of the things that I am just reminded of through all of this is partnership. We began to get phone calls from other organizations, other volunteers in the community saying, hey, what can we do collaboratively to come together to make an impact? And those ideals were coming together to buy lunch for the overworked DOC staff, coming together to write letters to the women and the men who are incarcerated, coming together and stuffing bags of goodies and encouraging notes and taking them into the men and women on the inside so that they can hear the message above all things is, you're not forgotten, we're still here, this is only for a season, and we will be back. And so did all that we could to get that message in there. But Jacqueline, I have to tell you, above all things, even though I've been so touched by all the positive stories that we've seen and heard on the outside, that is nothing in comparison to what I've seen coming from the inside. Hobby Lobby came alongside of us and some other organizations and donated a mass amount of material. And the men and women on the inside immediately began to raise their hands and ask the same questions that we've all been asking. What can I do to help? And so in that, we took material in, Hobby Lobby sent material in, all these volunteers were sending material in, donating sewing machines, and the men and the women on the inside began to sew. And they were sewing thousands, and still are today, sewing thousands and thousands of face masks. And as they sew the mask, we send volunteers out, or volunteers go out, they pick up the boxes, we're taking them to hospitals, nursing homes, all major facilities on the outside. They've sewn enough masks so that after the ones that Scott Crow gave to each inmate, or each man and each woman, now they're making their own so that they can have a change out of masks. They're doing all those things because, again, people incarcerated, men and women incarcerated, are just the same as we are. They're just people, and they want to help and they want to do these things. But I received letters this week, in fact, and the letters say things like, we're praying for you. I hope your family is doing well. We're forming prayer circles. So at the same time, we're keeping our social distancing to encourage one another. And so we're talking about a group of people who have been traumatized, addicted, abused, and because of some of the choices they made, they've ended up in a place of dire situation. And they are absolutely making the best of it. making the best of it. We are hungry and we are excited to be able to go back in. We understand the importance of waiting for those who are there on the front line to say it's okay. But in the meantime, these individuals have just done so much to me personally and to the women that I work with and the men that I work with to just encourage us. And that's been a beautiful thing. Thank you.
Thank you so much, Tammy. You know, I'm giving you a virtual hug. I was like, I'm not going to be able to get through Tammy's presentation without crying. So just barely, every time I see Tammy, I'm in tears. So I know that one of the questions that's come up, and I want to thank each and every one of you again so much for taking this time. Everyone's so busy, but this is such a critical issue. This is just the beginning of the conversation. It is ongoing, because while it's important that we advocate for safely and responsibly reducing prison systems, we can also walk and chew gum at the same time and advocate for our brothers and sisters that are incarcerated and make sure that they are safe and healthy. So I really appreciate this conversation and sharing that, because like I said, there's been some misinformation out there, and that makes it difficult for loved ones on the outside that can't get the right information. I do have one question that came up before the webinar, and this is probably for either Mary or for Mike. Are there ventilators available to DOC in the event that someone would require more extensive medical attention, or would there be provisions made to send them out to another hospital?
We don't have ventilators in our medical system because we don't have really the capacity, or our infirmaries aren't really equipped to have that kind of equipment. So if inmate needs care beyond what we can provide, they will be taken to local emergency rooms, or even, you know, if we're in rural areas, sometimes they get flown to a higher level of care around the Oklahoma City or Tulsa area.
Thank you for that. We still have a few minutes for some questions, or if our panelists want to ask anything of one another. Those were the questions that we have, and we have a couple of minutes. Or Chris, I don't know if you want to add anything.
Sure. I just want to take a second. Damien, Colleen, everybody's, Mike, the presentations, Tammy, that you guys gave today, it's just fantastic. I have long held and continue to hold that some of the most dedicated people in the state of Oklahoma work for the Department of Corrections. I just want to say thank you for all that you're doing. Damon, Colleen, Tammy Jo, the research, the effort that you put behind understanding what other states are doing, what could be happening here in Oklahoma that we may not be considering, that we should consider, is just awesome. I think this conversation, and I think the response that is taking place within the Department of Corrections, giving the abilities that we have, truly represents our state at its best. And I just want to say, Jacqueline, great job.
You're muted, Jacqueline.
I'm muted. I know. Almost made it through without a technical glitch. Thank you all again so much. This is very important for us to make sure to continue to advocate on behalf of everybody in the system. This affects not just the people or loved ones that are incarcerated, but the staff members that work there and come in and out of the DOC every day. So it's important that we continue to have these conversations. Thank you so much, Mary and Mike, Colleen, Damien, Chris, and everyone. Thank you to our attendees. This recording will be posted on our Facebook page, on the OCGR Facebook page, so you can look at it afterwards, and then we will have links to the bios for our panelists. So thank you all again. I appreciate your time. Thank you for spending time with us. We're going to take next week off, but come back the following week because we have fines and fees, another faith leader roundtable coming up, and bail reform. So please come back in June. We'll be off next week. Enjoy your holiday weekend, and thank you all so much for everything that you do. Bye-bye.
Bye, everyone.
Bye-bye, everyone.
Thank you, Mike and Mary.
You're welcome. Goodbye.
You're welcome.
Thank you all so much.